Okay, members, that was the end of listening to evidence about that particular petition. Now we're going to move straight on to our next petition. And as I mentioned at the beginning, we'll hear the evidence related to this and then we'll circle back and do our consideration of both of these petitions. So item 3 on our agenda is the petition, and I always have trouble saying this, so bear with me. The petition of associated myalgic in my head.
Sorry, I missed that. Can you say it again?
In my head, it sounds perfect every time until I go to say it out loud. But let me perhaps skip through and just say the ME Society Incorporated reclassification of ME CFS to a disability. And I'll hand over to you, Fiona, to make a much more eloquent deal of that. What is a very serious word.
Perfect, thank you. So tēnā koutou katoa, members of Parliament, thank you for the opportunity to present further testimony in support of our petitions. So I am Fiona Charlton, the President of ANZMES, which is the association in New Zealand for myalgic encephalomyelitis, which is also known as chronic fatigue syndrome. I'm joined today by Emeritus Professor Warren Tate and Royal New Zealand College of GPs Fellow Dr. Sarah Dial, who can answer your questions as well. We understand that you have invited representatives from Whaikaha and Ministry of Health to also speak today. In the written submission by Whaikaha, they recognise that ME fits the criteria for disability, but the responsibility lies with other government agencies to provide services. There is nothing dedicated to the unique needs of people with ME. The Ministry of Health states that the system doesn't require people with ME to be classed with a disability to access services, but this really lacks understanding of what happens in practice, unfortunately, what people with ME experience when trying to access services and what the reclassification would mean to people with ME. So we invite representatives to meet with us to discuss ways in which the government can better support people with ME, and key points for all of you to please consider and understand. ME is a disability. Post-exertional malaise is the cardinal symptom of ME, and it causes symptom exacerbation, which is often misunderstood and makes levels of disability difficult to assess without adequate knowledge and education of the condition. When you understand post-exertional malaise, you understand that people with ME have to choose between making a meal or attending an appointment outside of the house. They have to choose between taking a shower or doing the laundry. It is a constant battle between doing a task and the energy capacity to function enough to carry out those tasks. So ME is a disability because of this energy limited capacity. It is a condition that impairs the ability to function on a regular basis, both cognitively and physically, and this frequently confines people to their homes or their beds, causing unemployment and an inability to perform basic tasks of daily life. ME/CFS is a disability. There is no known cure. For many, it is lifelong. And ME is a disability. It fits the definition. And Whaikaha has also submitted that ME fits the definition. And the United Nations report to the government recommends that people with ME/CFS should have access to the disability support system and be included in disability policies and programs. So we actually created this petition to draw attention to the fact that the system is not working for people with ME. Many fall through the cracks. Many rely on whānau to care for them. Those who aren't lucky enough to have family to care for them will experience post-exertional malaise crashes regularly, just trying to make a meal or do laundry. And this means they're in a constant state of unwellness. Yet the eligibility criteria are inconsistent throughout the country, resulting in a postcode lottery for healthcare. Besides the direct practical ramifications for this, it is a health equity issue. The inconsistent criteria means that in practice, the majority of people with ME are unable to access services that the Ministry of Health state is available. People with ME are theoretically entitled to support under the chronic illness classification. However, they're not receiving it in practice. The Needs Assessment and Service Coordination, NASC, assess home help eligibility, and they confirm that ME patients are not considered for assessment. So the closest equivalent disease, multiple sclerosis, is accepted for assessment despite evidence that MS has lower prevalence and less associated functional disability than ME does. So the vast majority of people with ME do not actually fit the criteria for home help under the long-term support chronic health conditions designation, which is targeted at the over 65, those with very high needs or conditions such as diabetes. Even those with ME with very high needs that do meet the criteria get insufficient care, and the care role falls to family. For example, we have a 22-year-old with severe ME. She's bedbound, unable to feed herself, toilet herself, bathe herself. She's on a liquid diet. She's unable to speak. She's unable to leave her darkened room due to severe extreme sensitivities to light, sound, and touch. So her mother is now her full-time carer, leaving her nursing job, which has reduced the family income. Yet they've only been granted 22 hours per week of professional outside of the home care, and only 11 hours of this can be supplied due to staff shortages. So that mother who has given up paid employment to care for her daughter is only given 11 hours break per week. We call for standardized nationwide criteria and policies that recognize the severely debilitating nature of the condition, and we call for funding. Currently, there is no dedicated funding invested by the government for the wellbeing of people with ME/CFS, including no funding for research despite its increasing prevalence. In 2012, the House Select Committee recommended reclassification of ME to disability in our first petition, but this recommendation was not implemented by the government. We urge you today to also make this recommendation, but be active in ensuring this results in real practical change for people with ME, with recognition and access to services they deserve. Because early intervention actually promotes recovery, access to support promotes improved outcomes. It can help prevent further disability, further worsening of the condition, which often requires hospitalisation. Access to home help enables a person with ME to potentially do a work from home job if they can choose to use that limited energy on paid employment rather than making a meal, doing laundry, getting children off to school with a packed lunch, that sort of thing. But it's not just about home help for us. Being classified as a disability demonstrates that the government understands how truly disabling this condition is. It legitimises ME/CFS and provides protection of rights as a disabled person. It will enable them to fit the criteria for NASC assessment and home help services. Now, we do recognise that the government has done some work for people with long COVID. The advisory produced guidelines. There are long COVID clinics getting ready to open up in 4 main regions of Aotearoa. But people experiencing post-exertional malaise, which those with long COVID do, just like people with ME, will find it very difficult to make it to appointments. ANZMES and Complex Chronic Illness Support and other ME organisations have the solutions. We're already helping people with long COVID and ME. So please come to the table and discuss with us how best to supply the services required. We have the lived experience, the knowledge and the expertise. And finally, a change in classification would be a lifeline to dedicated support and wider acknowledgement that this illness is disabling, providing fairer access to established support and care. And we urge you to stand with us and help people with ME. Thank you.
Thank you, Fiona. It was really powerful. And I must, before I ask for any questions, I just want to acknowledge the fact that throughout the country, you've got some really great advocates and branches. I know the people in Canterbury who I've had several conversations with have done a really fabulous job of advocating on behalf of everybody. So we'd appreciate that. Are there any specific questions? Any comments anybody wants to make?
Just one quick one. Madam Chair, thank you for your submission. Just a quick one in regards to access inequity, and I'm just reading also your submission. Just around the numbers, I know that you say that the overall numbers is unknown, you've given an estimate, but also you've mentioned Māori and Pacific or probably underdiagnosed. Is it because health professionals may not understand or diagnose it appropriately, would you say?
Sarah, would you like to answer, or Warren?
Yep, I'm a GP in Rotorua, and I think one of the problems for Māori and Pacifica is just accessing primary healthcare where this is diagnosed, and that knowledge that's held by GPs. So a lot of GPs are not familiar with how to diagnose ME/CFS, and so patients often have to get that diagnosis from a practitioner that does know about ME/CFS, which is not funded. So, for example, patients may need to come and ask for a consultation to see me privately, and there's no funding available for that. So it's poor access and poor knowledge.
What we've found over the years is that there's very limited knowledge in the realm of GPs in primary care. And so we've actually produced our own education. So at the moment, we have a program that is for health professionals that educates them about ME and long COVID, post-COVID conditions, which is accredited by the Royal New Zealand College of GPs. We've had to do that because we find that the knowledge and expertise of ME is very limited in the population of GPs. Warren, you wanted to say something?
Could I add to that? A year or two ago, I submitted a grant for long-term conditions, that portfolio of research that was being offered by the Ministry of Health. And I'd organised, part of that program was going to be oral history with the Runanga and Otago, to go into Maori communities to learn, how they were dealing with the illness and what the incidents were. And I got a response from the ministry that really they wouldn't give funding for ME/CFS alone to do this kind of thing. So it has been very frustrating as a researcher that we haven't been able to get in and access the information of the incidents of ME/CFS in Maori and how they actually cope with it. And I think actually they probably cope with it in the culture in a way which we could learn a lot from them. So it's been a frustration for me.
Thank you.
I know one or two now Maori students who have been suffering from it, so I'm starting to get some personal contact.
Great, thank you for that, Warren. And I'm conscious of the fact that we are over time and we're running a bit late, but there's some threads there that we can perhaps pick up as we move through our program with other submitters and ask those questions in a bit more detail. But thank you for raising them. Appreciate your time.
Thank you. Thank you.
Thank you.
Thank you.
Next, we're going to hear from Whaikaha, and I believe we are here in person. Welcome. So Trish and Helen? Yes. Excellent. Thank you for being here, and apologies for running late, but it's a really interesting subject matters this morning, so it's best that we take some time. I'll hand over to you to do your introductions, and then you have 10 minutes. Thank you.
Ngā mihi nui, kia koutou, ko Trish Davis Tukwingwa. I'm Trish Davis. I'm the Acting Chief Advisor for the Operational Design and Delivery team in Whaikaha.
Tēnā koutou katoa, ko Helen Walter aho. Kia ora koutou, my name is Helen Walter. I'm the Group Manager of Policy at Whaikaha.
Thank you.
Kia ora. I would like to thank the Health Select Committee for the opportunity to provide a submission on the petition initiated by the Associated New Zealand Myalgic Encephalomyelitis Society, which is calling for myalgic encephalomyelitis or chronic fatigue syndrome, or ME or CFS, to be reclassified as a disability. Whaikaha, the Ministry of Disabled People, was established on the 1st of July in 2022. Whaikaha incorporates the Office for Disability Issues and the former Disability Directorate of the Ministry of Health. Funding and responsibility for delivering and transforming the disability support services for eligible people and their families was also transferred from the Ministry of Health to Whaikaha at the time. ME or CFS is recognised as a disability under the United Nations Convention on the Rights of Persons with Disabilities, or the UNCRPD. The UNCRPD describes a social model of disability where the person has an impairment, and it is the interaction with barriers in society that causes the disability. Disability includes people with long-term physical, mental, intellectual, or sensory impairments. In New Zealand, no one agency is responsible for funding and delivering services and support for all disabled people. Rather, it is shared across several government agencies. Government agencies apply their own eligibility criteria to identify those who may require additional government-funded services and supports. Although those who have may have sole ME or CFS and also long COVID do fall within the broader UNCRPD definition of disability. They don't fit within the current eligibility criteria for assessment to access most Whaikaha funded disability support services. However, people with ME or CFS who have a coexisting intellectual disability, sensory or physical disability, or autism are eligible to be assessed for a range of Whaikaha funded disability support services. Their impairments must also be likely to continue for at least 6 months and limit their ability to function independently to the extent that ongoing support is required. As Whaikaha is still in its establishment phase, no decisions have been made on changes to the eligibility policy. So at this time, there has not been any decision by Whaikaha on any reclassification of ME or CFS as a disability. Te Whatu Ora, or Health New Zealand, is the primary agency with responsibility for funding or providing services and support for people with chronic health conditions such as sole ME or CFS, and also long COVID. A key consideration for Whaikaha is that it is not a ministry that provides everything for all disabled people. Rather, all government agencies must work to ensure that policies, supports and services within their responsibilities support the full participation of disabled people. As Whaikaha moves out of its establishment phase, it will have more opportunity to focus on the wider stewardship role for disabled people. Thank you for the opportunity to make this submission on this important matter.
Great, thank you so much. I've got a question from Sarah Pellett first up.
Kia ora, thank you for your submission, helpful. This is quite a specific question. What benefit do you think it would bring to those people who are suffering from ME/CFS should it be classified as a disability and then fall under the umbrella of Whaikaha?
Whaikaha has a range of services that are mentioned actually in the petition that people with ME or CFS are seeking, and so they're the broader conditions, so things like home-based support. So it does look like, based on the petition, that people are seeking a wider range of services that are currently available, and also that the criteria is different for accessing them.
So what you're saying is that you do feel that they would have access to a greater range of support services if it were classified as a disability. I mean, because what I'm hearing is that for some people, they do meet the criteria, but they're not able to access the support. But you think that this potentially would smooth the way for them to actually enable them to get the support that they need? Potentially. There's benefit is what I'm trying to get at, you know.
Well, technically, those services are also available within Te Whatu Hauora, and it is in terms of the criteria may be different though to what's available.
Yeah.
So there's very similar services available through Te Whatu Hauora and also to Whaikaha.
Okay,
I think
thank
that's
you.
good. Moving on, Dr. Shane Reti, please.
Tēnā kōrua. Can I ask, please, have you modelled the fiscal impact of ME being qualified as a disability?
No, we haven't done that.
Soraya Piki Mason.
Thank you, Madam Chair. I'm Mahiana Kia Korua. My question is just, a comment. Thank you very much for your submission. It's just around the importance of collecting data. It'd be good to, if you haven't already, collect data around Māori and Pacific Island access to the work that you do and the services that you do offer. But thank you very much.
Perfect.
I
Thanks,
think,
Severin, please.
thank you, Madam Chair. Thank you, guys, because I know you guys are still pretty new and still finding the feet and all that. But like, sort of just not just with ME, but with a lot of other disabilities that we've been hearing around, is that no cohesionness between what they can actually access and, you know, and I sort of saying is it for some way, those with any form of disability, they have maybe somewhere that they can go and then know where they can get that help, especially like not only with ME, but also long COVID and things like that. And because I also know like with Barr virus, people get long-term fatigue and things like that, especially young teenagers. I know that they'll end up with a disability, but these things, you know, if you don't know where to go or how to navigate through our systems, they fall through the crack. And this is where I would hope that Whaikaha would probably come in and help to make it a little bit easier with those with disabilities to be able to navigate where they can find the services if they're entitled to them. And I think this is another issue that they're saying is people not being able to get the right access or who to see. It's very disjointed, I feel, at the moment, and whether or not that's something that you guys are planning to sort of work towards.
That is part of the plan in terms of the New Zealand disability strategy. We are required to report on that. So access and knowing what's available is a really big issue. So that is work that we are currently doing, but it will increase as we look at how all of government is performing in this area.
Oh, thank you very much, Trish and Helen. Much appreciated. And thank you for being here in person as well. We appreciate that. Thank you. Next, we're going to hear from the Ministry of Health, and I believe we've got Martin Chadwick joining us via Zoom.
Try unmuting. Kia ora katoa, ko Martin Chadwick aho, ko ngā Apiha Hauora Haumi, Manatū Hauora. So kia ora, so I'm the Chief Allied Health Professions Officer within Manatū Hauora, the Ministry of Health. I'd just like to thank the panel for the opportunity to provide an oral submission today. We do want to note the issues raised by the petitioners with regards to the need for people experiencing ME/CFS. There are 4 key points that I would like to make today in support of my previous submission. The first point is that the health system does not require conditions to be classified as a disability for people to access services. Access to health services is based on clinical need and capacity to benefit. All people who meet the eligibility criteria under the Health and Disability Services Eligibility Direction of 2011 are eligible to access publicly funded health services. There is important to note that there is no need for a health condition to be classified as a disability in order to be able to access these services. The second point I'd like to make today is that the health system offers services that are appropriate for people with ME/CFS, and noting that Te Whatu Hauora is the operational agency for the health system and is responsible for providing services to communities. The government provides prescription subsidies for many New Zealanders, including community service card holders. Additionally, the prescription subsidy scheme, once the first 20 prescriptions have been paid for, all other items during the year are free. And just noting that a household can combine items to count towards 20 prescriptions. So just noting the access to services and also for medications. Third point today is that Manatū Hauora has led work on the impact of long COVID, and we are in the process of transferring this work to Te Whatu Ora for ongoing support. Specific work has been undertaken in anticipation of the impacts of individuals living with ongoing symptoms due to COVID-19 infections. Specific actions that have been taken include convening an expert advisory group, which includes individuals with lived experience with a focus on more affected populations. The work of the expert advisory group developed clinical guidance for managing ongoing symptomology following an acute infection. This guidance contained information for clinicians as well as for people living with ongoing symptoms. We did also conduct continuous evidence reviews to inform the development of the clinical guidance, and this has been published in parallel with the guidance documents themselves. Lastly, we have developed and implemented specific coding to allow for data to be able to capture people presenting to their GP with long COVID symptomology, as well as in hospital settings. Currently, Manatū Hauora is in the process of transferring this work to Te Whatu Ora for ongoing updates. My final point for today is that the health of people with disabilities is being prioritised through the health reforms. Specifically under the Paiora Act of 2022, it requires the Ministry of Health to develop a range of strategies for specific population groups and includes Health of Disabled People strategy. Manatū Hauora is leading work on the strategy, which includes engaging with a wide range of organisations across the disability sector. The Health of Disabled People strategy will contain an assessment of the current state of health outcomes for disabled people and the performance of the health sector in relation to disabled people. It will also contain an assessment of the medium and long-term trends that will affect the health of disabled people and the health sector performance, and set out priorities for services and health sector improvements relating to the health of disabled people, including workforce development. Te Pai Tāra is the interim New Zealand health plan published by Te Whatu Ora and Te Aka Whai Ora also make a number of specific comments related to the health of disabled people, the implementation of these commitments. So those are the 4 key points I'd like to make today. So thank you.
Thank you, Martin, much appreciated. I've got a question from Steph Lewis first up.
Thank you, Madam Chair. Although you said that in order to receive services, it doesn't, an illness doesn't need to be classified as a disability, would you agree, though, that having it classified as a disability for those who experience ME, CFS would validate them, which can have some, I guess, mental benefit because they feel heard? And following on from that, would you agree that having it classified as a disability, would they receive any more joined up support rather than having to sort of agency hop to get the support that they need?
Yeah, so a couple of points that sit within that. So I think the first is with regards to the classification as a disability, and I think it's acknowledging the UN convention under which has been quoted today, and that's very much a social construct, if you will, of defining disability. So I think the way that that is used would reinforce your point about giving affirmation for people that are living with a disability, because it is coming from a social construct. So I think in support of that, I think what I'm talking through today is very much coming from a provision of health services and trying to really reinforce the point that be with a disability or without a disability, it is not a barrier to access those services. As I read through the petition, I think one of the key points is the access to more of the social help services, and that would be enabled, because I think the point around NASIC services, the ability to access some of those additional social supports would be enabled more so.
Thank you for that clarification. That's really interesting, and I appreciate that question, because it's good to, as you say, parcel out those 2 specific concerns about access to health services versus
Social services.
the social services and the internal kind of validations that all of that arise as well.
Yeah.
Any other questions? All good. Thank you so much for your time, Martin. Much appreciated.
Okay. Thank you. Kia ora.